Okay, well, in the interest of time, I think we'll get started. So welcome everyone to today's ACLP Virtual Journal Club session. Just as a reminder, we're working our way through the ABPN's article-based pathway for maintenance of certification for CL psychiatry. So if you are interested in presenting one of these papers in the future, please feel free to let me know and we'll definitely figure out how to make that happen. So for today's Journal Club session, I'm very pleased to introduce Dr. Monty Meyer. Dr. Meyer is an assistant professor of psychiatry at Harvard Medical School and a staff psychiatrist affiliated with Brigham and Women's Hospital and Dana-Farber Cancer Institute. Her work focuses on transplantation and cancer psychiatry, and she's also the psychopharmacology didactic thread leader for the Brigham Psychiatry Residency Program. Today, Dr. Meyer will be talking about a 2016 article entitled Selective Serotonin Reuptake Inhibitors and Operative Bleeding Risk, a review of the literature. In terms of logistics, Dr. Meyer will speak for about 20 minutes or so, and then we should have about 9 minutes for discussion. If you do have any questions for Dr. Meyer, please use the Q&A feature that's located down at the bottom of the screen. I will take a look at all of those, and I will try to either answer them in the chat if we need to, or keep them for Dr. Meyer to answer at the end of the talk. With all of that said, I think we can get started. So Dr. Meyer, please feel free to take it away.
Thank you so much, Dr. Solano. Thanks so much for inviting me. And I'm really excited to be part of this project. Dr. Christine Pellick, who's the chair of the ACLP Maintenance of Certification Committee, of which I'm a part, had this great idea, along with Dr. Solano, to go through and present some of the articles for the MOC pathway. So hopefully my review will be helpful for those of you who are in the middle of your articles. But beyond that, I'll also aim to provide some general clinical pearls about the topic. And I have no disclosures. So starting off, I think it's important to think a little bit about how major depressive disorder inherently affects platelet function before we get to the paper specifically. So essentially, patients with depression seem to have an alteration in platelet aggregation. Their platelets aggregate more strongly, are more reactive to mild stress, and there's an increased amount of procoagulatory peptide secretion, as well as a greater density of certain receptors that govern platelet aggregation. And so all taken together, all of these findings may explain the increased risk of ischemic vascular disease associated with depression, as well as the increased mortality after heart attacks in depressed patients. And some years ago, Dominique Musselman, who's a CL psychiatrist, I think still in Florida, did some R01 funded research on depression and platelet function. And one of her seminal papers looked at normal versus depressed patients at baseline and looked at this platelet anti-ligand induced binding site and found that patients with major depression have a lot more binding there than normal controls. The study also looked at treatment, the effect of treatment with open label paroxetine for 6 weeks. And after 6 weeks, the same binding at anti-LIBS1 was not significantly different than that of normal controls. So she was able to demonstrate that an SSRI perhaps reversed some of the impact of depression on platelet function. And this will become important later as we talk about SSRIs and their effects on platelets. So now moving along to serotonin and platelet function. So serotonin, as we know, is taken up by the bloodstream by the serotonin transporter. And in platelets, serotonin is stored in dense granules. When platelets are then activated by a variety of activating factors, thrombotic factors, pro-adhesion factors, among others, these activators then bind to G protein-coupled receptors at the cell surface, and they trigger a cascade of events which result in the release of serotonin from platelets into the periphery, generating what we call activated platelets. And so SSRIs, as we know, block the serotonin transporter and result in about a 65 to 90% reduction in platelet serotonin content. This reduction leads to a decrease in the secretory response and aggregation of platelets. And the consequent antiplatelet effect is actually thought to have a similar magnitude to aspirin, and importantly, is probably unconnected to the antidepressant effect. So whether or not a patient responds to an SSRI therapeutically, they'll still have the consequent effect on platelets from that SSRI. And it's thought that this may be the mechanism by which SSRIs reduce cardiac mortality after myocardial infarction. So now we'll go to the paper, which is by Stephen Roos and Brett Rutherford, and it's a review of the literature on operative bleeding risk associated with selective serotonin reuptake inhibitors. And this narrative review looked at about 30 years worth of studies reporting information on bleeding complications during surgery or childbirth in patients taking antidepressants. And the study and the paper itself reviewed, it was a review of reviews, so it reviewed 19 retrospective chart review studies in SSRI users versus non-users, based either on self-report, usually also on pharmacy records. None of these studies were prospective or randomized. So starting first with orthopedic procedures. So there were 7 studies that were looked at pertaining to orthopedic procedures, mostly joint replacement surgeries, but also some spinal fusion and fracture repairs. And in 6 out of 7 of these studies, the authors found higher odds ratio for bleeding in patients who are currently on SSRIs, so higher rates of intraoperative blood loss and or need for transfusions during surgery. And then turning next to CABG. So there were 4 studies looking at bleeding complications after CABG. And one important caveat here is that generally for non-cardiac surgeries, patients have some kind of preoperative appointment and they're advised to stop NSAIDs, aspirin, and any antiplatelet agents 7 to 10 days before surgery. In contrast, for cardiac surgery, often patients are asked to continue on aspirin throughout, and sometimes are asked to discontinue Plavix and are always advised to discontinue warfarin or other anticoagulants. But there may be some use of antiplatelet agents leading into CABG for a lot of patients. So with that context, 3 of these studies did not find increased bleeding in patients on SSRIs. In one study, there was an increased rate of transfusion, but not of reoperation. There were some methodologic issues with 2 of the studies. In one of the studies, SSRI use was defined as medication within 3 months of surgery. This may be too liberal of a definition because really the effect of SSRIs and platelets would be confined to use probably within about 2 weeks of surgery. So that may be too broad of a definition. And then in one of the other studies, the non-SSRI antidepressants included medications that had some serotonin reuptake inhibition, like TCAs. So that might have washed out some of the effect as well. Then the authors turned to breast, cosmetic, and postpartum studies. So in the 2 studies of breast surgeries, there was a significantly increased risk of reoperation, odds ratios of 2 and 4 respectively, requiring reintervention, reoperation. And this actually is something that I knew about these studies for a while, having done psycho-oncologies, and I saw a lot of breast cancer patients when I worked at DFCI. And so this did change my practice a little bit. So sometimes if I would see a patient who had some degree of depression or anxiety, and I had the opportunity to start an SSRI, I would wait until they were through the next stage of their breast reconstruction and wait about a week or 2, and then I would advise them to start the SSRI at that point. So that did actually impact my practice some when I was there. It is important in all of these studies to keep in mind the difference between relative and absolute risk. So, these odd ratios all reflect, of course, relative risk. For example, in the Gartner study, the relative risk of reoperation is 2.3. But the absolute risk of reoperation remains fairly low. So in the Gartner study, the SSRI increased the absolute risk from about 3% to 7%. So not insignificant, but also it's still a low risk of reoperation. The facelift study showed no difference. The 2 postpartum hemorrhage studies, one had some methodological issues, as we discussed previously, about patients who may have been on SSRIs earlier rather than immediately before delivery. And then the other one did show some increase in risk. And then finally, there were 2 studies of one of dental extractions where there was no difference, and another study of PEG tube placement, which did show an increased odds ratio of bleeding in SSRI patients. So this summarizes all the disease-specific studies. And then there was a quite large review that they also looked at, which I actually think would have been also an interesting study to present in Journal Club, or to have had, or for the ABPN to have assigned. This study looked at more than 500,000 patients who are having major surgeries. More than 70,000 of those received an SSRI in the perioperative period. And again, this demonstrated a greater bleeding risk in those patients, and a higher mortality rate as well. So this study did attempt to adjust for comorbidities that were more frequent in the SSRI group, things like depression, obviously, but also medical comorbidities like COPD and obesity that may increase bleeding risk. And also did several sensitivity analyses, including for concomitant use of other anticoagulants, aspirin, NSAIDs, et cetera. And interestingly, in this study, the elevated bleeding risks were also seen in patients who were on the SSRI only in the post-op period. So this raised for the authors the question of whether SSRI should be held for an additional period of time after surgery, not immediately restarted after the surgery is complete. So that brings us to the issue of timing considerations. What if you did, in fact, want to stop an SSRI before a surgery with this risk in mind? You would need to stop at least 2 weeks before any procedure to allow for the generation of new platelets unaffected by the mechanisms we discussed. And this would have to be longer for fluoxetine, more like 4 to 6 weeks. And so if you think about the logistics of doing this with an outpatient or with any patient, you might be tapering to discontinuation, doing so gradually. And so if you think about that, certainly a patient could be off a previously therapeutic dose for at least 6 weeks in the context of this process. And so that's where you have to start thinking about the risk and benefit ratio of doing this. So the risks, obviously, there's a substantial risk of discontinuation syndrome, which can be mitigated by a slow taper. Perhaps the more important risk, although not totally unrelated, is, what if someone actually has a recurrence and worsening of their underlying psychiatric disorder? And trying to stratify this, looking into the literature about this risk was sort of interesting. I found that a couple years ago, there was a RCT that was published in the New England Journal kind of going to this question. They looked at euthymic patients who had been on antidepressants for over 2 years or who had more than 2 previous depressive episodes. And they randomized those patients to either maintenance or a 2-month tapered discontinuation of antidepressants. And their findings were that 39% of the maintenance group and 56% of the discontinuation group relapsed within 1 year. And this works out to about a 3% relapse rate per month for the maintenance group and a 5% per month for the discontinuation group. So, you can see from that data that there are a number of patients that you can safely taper off antidepressants. The question is patient selection. How do you pick which patients? And I think that's where our expertise as psychiatrists come in terms of careful patient selection in this regard. It is possible. It's not possible for everyone, as we know, depending on what the underlying psychiatric risk is. And then obviously the benefits of doing this would be to reduce bleeding risk in a specific patient. Again, every surgery is different. Every patient has their own individual probably likelihood of bleeding. Every surgery is different. So it's really hard to quantify the magnitude of this reduced risk in a specific patient. But overall, obviously, this could be an impetus to reduce polypharmacy and to peel off kind of unnecessary medications too. So the authors in this review paper that we've been talking about do suggest categorizing patients in terms of the risk of doing this. And I would say that I think we would all agree that patients with significant safety issues, suicide attempts, hospitalizations with treatment-resistant illness, it might not be a good patient population to consider making any changes in. There's an intermediate category of patients with recurrent illness, but that illness that is perhaps more treatment responsive and less severe. And we do see some of these patients in our ambulatory NCL practices, and they may be candidates. And then they propose that patients who are kind of being on the end of treatment for an initial episode, or patients who are on an SSRI without really a clear indication, those may be good categories of patients to consider making changes before major surgery. And so you might wonder about other situations to consider beyond elective surgery. So upper GI bleeding is one that we definitely think about as well with SSRIs and other medications impacting serotonin reuptake inhibition. So the odds ratio is elevated, about 1.7 overall with SSRIs, and then it's higher, more than 2 times that with a combination of SSRIs plus NSAIDs. And then hemorrhagic stroke. There's an elevated odds ratio as well with SSRIs, and there have been several studies suggesting that stroke severity and mortality is also more significant in patients who were on an SSRI at the time of their index brain hemorrhage. So I would say that, like, clinically speaking, we're going to go through a scenario about upper GI bleeding, but certainly for hemorrhagic stroke, if there's a patient who has this in their history, I would be inclined to trial medications with a different mechanism first, just out of an abundance of caution. So what are some clinical things that we can maybe glean from this paper? So I would say that for if you're doing inpatient CL, it's all the efforts that we make about confirming preoperative indication for SSRIs are certainly helpful here. And then I think confirming adherence is helpful if you're seeing someone after a major surgery. I often wonder about us putting people, when we do the medication reconciliation in hospitals, if we end up putting people on medications that maybe they weren't truly fully adherent with before their hospitalization. And this actually could produce some bleeding risk in a subpopulation of patients. And so for outpatients, I myself do a lot of outpatient CL and a lot of outpatient work generally. And so as I was preparing these slides, I thought to myself, I should be more diligent about knowing, kind of when exactly my patients are having elective surgeries, and in case I want to do any planning about this. So I think that's an important thing to think about as you're following along with your outpatients. If you end up making the decision in any case to stop and restart the SSRI, I would say it's prudent to wait to restart it until past any critical window and period of bleeding risk. And this could be as much as 8 to 10 days for major surgeries. That timeline is extrapolated from the previous paper that I mentioned, the big study that showed that there were elevated bleeding risks even in patients who just took the SSRI immediately peri-op, but also from national guidelines around when do you resume chronic aspirin therapy. Usually it's advised about 10 days after surgery that someone could resume their chronic aspirin. And then the other thing that I think is important to do with your long-term SSRI patients is to educate them a bit about the GI bleeding risk, especially additive risk with NSAIDs. Of course, our patients take NSAIDs at varying rates and frequencies, and so they're over the counter and we don't know unless we ask. So I try to remember to talk to my SSRI patients about that issue. And the other thing, I have been seeing a ton of iron deficiency in my outpatients. I feel like it's more common than ever before. Maybe it's just being more frequently diagnosed than ever before, but it's worth kind of thinking about if you have a patient with depression, but ongoing and prominent fatigue, about doing a CBC and iron studies as part of a workup. And certainly iron studies, the most sensitive one is ferritin and transferrin saturation are the best ways to diagnose iron deficiency, which might point you to some underlying bleeding that's going on, and also can be treated, obviously. So it's recommended to check both because the ferritin is a iron storage protein, but also an acute phase reactant. So it's increased in inflammatory states, and so that can mask iron deficiency. So it's recommended to utilize both transferrin saturation and ferritin to diagnose this. And so then as I was trying to tie up what I would talk about, I was thinking, well, I should try to find a clinical case of relevance. And it didn't take very long because I was like pre-charting for the next day. And a patient that I thought was kind of relevant in light of this talk was on my schedule. So I'll tell you a little bit about her. So this is a 51-year-old premenopausal, still menstruating woman with mild depression, GAD, restless leg syndrome, irritable bowel syndrome on bupropion, escitalopram, and pramiprazole. So I was looking back through her history and synthesized things as followed. So basically, she had a history of iron deficiency during the pandemic with no intervention. I think partly because of the pandemic. A couple years later, she had been on escitalopram all this time. I stopped it actually due to emotional blunting, and she was fairly euthymic otherwise. She remained on bupropion. Middle of 2022, she develops worsening clear-cut iron deficiency, starts oral iron, stops NSAIDs. It gets worse, despite the fact that she's off the escitalopram, although I suspect her iron deficiency had been building over many years. She did not respond to oral iron, had a negative bleeding, GI bleeding workup, but actually did have fatigue and dyspnea at this point from her iron deficiency. Proceeded to receive 4 iron infusions. Her restless legs, which she had had for years, improved. Her iron studies and CBC normalized. And at this point, her menses, which she claimed were normal, not particularly heavy, were beginning to lighten. Everything normalized. So then flash forward to this year, she started having breakthrough irritability and anxiety in the setting of some other psychosocial stressors. So I started sertraline on this occasion at a low dose. And when I was chart checking the night before, I discovered that she had been reporting new rectal bleeding for the last couple of months and was being referred back for another colonoscopy. So thinking about this, what we just presented, I do wonder a little bit about some kind of synergy between whatever else she has going on and any potential contribution of an SSRI. And, so I'll be talking about this with her at her next visit. So I think if you think about your patient population, this may have more relevance than even it seems on first blush. So I think there are other clinical scenarios that we could go over as well. But that's all the time we have. So I would like to thank the ACLP committee for inviting me to give this webinar, and happy to take any questions.
Well, thank you very much, Dr. Meyer. That was great. Yeah, super interesting. I mean, I think thinking about the relationship between depression and cardiovascular disease and poor cardiac outcomes is interesting. And then I think it was also really interesting to think about the differences between the different types of surgeries and maybe think a little bit about what kinds of surgeries I would be most worried about or most likely to kind of stop somebody's antidepressant medication. But let me ask you a few questions. Several came in, which is great. So thank you everybody who submitted them. I guess one was kind of thinking about SSRIs versus other anticoagulant medications like aspirin and antiplatelet agents and warfarin. How does the risk, of SSRIs compare to those other kinds of medications, and how worried should we be about those?
Yeah, I think that's a great question. So I didn't look at it for every single study that was all 19, but I looked at it in a good sample, maybe 5 to 6 or 7 papers. And in several of them, like for example, in a couple of the orthopedic procedure studies, they actually found similar magnitude of odds ratio increase for transfusion as to what has been reported for antithrombotics and NSAIDs. So that's of some concern.
Yeah. Okay, great. Another question kind of came up. So if you did want to taper somebody's SSRI, would you have any thought about using a different antidepressant medication? I think you had bupropion listed before as something that the case you were discussing that woman was taking. But what would your options be, and how would you think about if you wanted to use an alternative and what you would choose?
Yeah, I mean, I think it would, of course, depend on whether I felt I needed something else to control their symptoms, but I'd be inclined to use bupropion because it's more of a norepinephrine acts more at norepinephrine and dopamine, and/or mirtazapine, I would say, has less strong serotonin reuptake inhibition. So probably those would be my top 2 antidepressants. And I would certainly categorize most TCAs similarly to SSRIs, and put them in the same, like, slightly higher risk bucket.
Yep. And I think one question came in about any differences between SSRIs and SNRIs. Have people looked at SNRIs, or would you expect there to be a difference?
Yeah, in that big study that I mentioned, the one that had like over, I think 700,000 patients, they found they did a subgroup analysis on SNRIs, and the odds ratios were quite similar to SSRIs for increased bleeding. So I think it's quite similar. The situation is quite similar for SNRIs.
Great. I guess one other question, which I think maybe you kind of answered in kind of in a different way. If you had somebody who had a post-hemorrhagic stroke and was in rehab and developed depressive symptoms, how would you think about approaching treatment of them? And from a medication standpoint, I guess, or from another standpoint, a therapy standpoint.
Yeah, I mean, I'd probably start with therapy, and I think I would probably start with a non-SSRI, like some, again, like a mirtazapine or bupropion type approach. I don't know that the data is such that we would say using a medication with serotonin reuptake inhibition would be absolutely contraindicated. Especially, I mean, I would be looking at the stroke too, and what was noted about the etiology. I mean, I think it's very different when if someone has an aneurysm or something, and the aneurysm has been clipped and repaired, I'm not as worried about it. But if it was idiopathic and they had no hypertension and no alcohol use disorder and no aneurysm, I might be a little bit more worried about some kind of vasoactive effect of the SSRI. So I still probably wouldn't start with one, but I don't think they're absolutely contraindicated if I had to get to that point.
Yeah. Great. I think one other question that came up. So in terms of a clinical scenario, let's say you have somebody who is on an antidepressant, comes into the hospital, needs relatively urgent surgery while in the hospital, and they're on the SSRI. Do you stop it while they're there? Is there a benefit, or I mean, given the length of time it takes to get out of their system and the new platelets to be generated, is it
Yeah.
better to just keep them on it?
Yeah, that's a great question. I mean, I think I probably, if I didn't have at least 10 days, I don't think I would bother, based on the evidence and where it's at currently, because I don't think there would be enough time to really reverse the effect.
Yep. Right. Yeah, I was thinking the same thing. It seems like at that point, you're not going to really, it's not going to
Right.
get out of their system. And if you're going to restart it in 8 to 10 days anyway,
Right. And I mean, it might help a little bit after the surgery, but my feeling is as soon as if it's still in your system at the moment you have the surgery, you're still going to have that higher bleeding risk, no matter what happens if you stop it after. So I think, yeah, I think you've got to have enough time to be able to properly plan this.
yeah. Okay. Great. And then I think one other person had a question about ECT. The question isn't very detailed, but do you have any concerns about using SSRI? Like, would there be a bleeding risk related to ECT, or any concerns about using an SSRI in those patients?
Yeah, I don't. Again, I think that a general neurological evaluation for ECT should suffice. If the question is about sort of risk of brain bleed, I think a general neurological evaluation would suffice. And that way, whatever's part of the normal medical clearance. Certainly, I would say that many, if not most, of our patients receiving ECT are on SSRIs, and so I'm not aware of a study specifically looking at that any specific risks in that population. But I would say that we certainly have a fair bit of experience with that based on who gets ECT.
Cool. Okay. Well, I think we are out of time. So thank you, Dr. Meyer, for presenting this today. Thank you, everybody, for joining for the ACLP Virtual Journal Club. Again, if you are interested in talking about one of these in the future, please feel free to let me know. Our next journal club will be in August, and so we look forward to hopefully seeing you then. So thanks, everybody, and have a great week.